it's really a great opportunity for those of you that weren't able to be a part of it. Just try on your lunch break, even if it's only part of your lunch, just to see how it is. I was amazed at how much we learned, and there's so much more that we can cover. So it's a great opportunity. So to begin with the family planning protocol updates, we wanted to start by showing an important resource to staff. This is the family planning web page, which is referenced here, the link. And that's where you're going to find the current protocols, the forms, training information, also information about teen services, birth control information, health data reports. And we have received a few questions about how to navigate the website to get to the protocol, so we're just going to take a few slides to explain how to find it. Once you click on that link or put it into your browser, it's going to take you to the home page, and you'll look for service providers under Learn More, or on the right-hand column, you're going to look for providers. There's pictures here on the screen that'll show you what these look like on that home page. So once you get to the service providers page, this is where you're going to find the most current protocols, forms, training links, and resources. Remember to always come to this page for the most current form so that you're never guessing if what you have printed out is current. And then, of course, as most of you are aware, we update the family planning protocol annually. And so every year after you've looked at the revisions, we ask that you print out the approval page, which is shown here on the screen, sign it, and this copy will be maintained at your site. And they'll actually look at this when they go through the site visit. Another really good resource that those of you that have been on the Reproductive Health Echo have heard about, and maybe some of you also have heard about, are the U.S. Medical Eligibility Criteria, or the MEC, and the U.S. Selected Practice Recommendations, or the SPR. These were updated in 2016, and we do have them in the protocol Appendix G and H, but there are some really nice apps and resources that you can get and use in clinic. The links here are on the slide, but you can also do a search on the CDC website and download those for reference. So another update this year was regarding notices and signs. Clinic staff should ensure that all notices and signs posted are in the primary languages of the population served. This was actually a federal site visit finding last year, so we wanted to mention it during the update. Then, in Section 1 of the protocol, there were some updates to the Public Health Nurse Quick Start Standing Order. And they now reflect the new 2016 MEC recommendations regarding medical conditions and precautions. And in the protocol, those are highlighted in yellow, so they'll stand out for you. So on the screen, here's listed for the oral contraceptive pill Quick Start. The 2016 MEC updates included the addition of multiple sclerosis with prolonged immobility. That's a Category 3. Just a note here, MS without immobility is a Category 1. Then we have the low HDL, high LDL, or high triglycerides were added to the multiple risk factors for atherosclerotic cardiovascular disease. It's a Category 3 to initiate and a 4 to continue the method. And again, remember, there's, according to the CDC, this is a quote, few if any screening tests are needed before you can initiate contraception. So these are just known health history of the client. Also, acute or history of superficial venous thrombosis was added. That's a Category 3. And for the antiretroviral therapy, FPV is a Category 3. All other of the ARVs are a 1 or a 2. Again, keep in mind that this is a quick start standing order for public health nurses. If the client's medical history causes any concern for the nurse, they should contact a clinician for further guidance. And then looking at the depot quick start, one addition from the 2016 MEC was again that low HDL, high LDL, or high triglycerides added to the multiple risk factors for atherosclerotic cardiovascular disease, and that's a 3 for depot use. So we mentioned the shared decision-making tool before. This year, though, we more fully integrated it into the protocol. So again, a reminder, shared decision-making should be used to work with clients interactively to select the most appropriate birth control method for them. And the client's preferences should guide the birth control method decision. So it isn't just the tiered approach, it's based on the client's input. Section 1, we include this birth control methods options chart, which can be used during the shared decision-making counseling if that's helpful. And we do have an English and Spanish version that we've laminated that we'll be sending out to clinic sites in case that's helpful for you to use in clinic. And if you want additional copies, of course, you can order them. In Appendix C of the protocol is the education resource order form, so you just complete that and send it in. Moving on to Section 2. First change here is in the method-specific consent forms. So these are the IUD and the contraceptive implant consents. Great news is that these are now only needed when a client requests removal and or insertion of the IUD or the implant. And I know if you weren't all muted, I could hear you clapping. You won't need to do these annually for everyone. They're only for the insertion or removal. We used to require this annually or for continuation of the device, but we no longer require that. And then the Paragard consent. This year we've added an option of inserting the Paragard as emergency contraception into the protocol this year. And because of this, we've added some additional areas to the Paragard consent form. And they help identify additional symptoms or risks that the client should be aware of. And there's also change in options at the bottom of the form, as you see highlighted here, that the client can check if they're voluntarily requesting to have the insertion of Paragard as ongoing contraception, or the insertion of Paragard as emergency contraception in addition to ongoing contraception, or for the removal of the Paragard. And so, as I just mentioned, the copper IUD or Paragard has now been added for use as emergency contraception in our protocol, and again at the discretion of the clinician. Additional tools were added to this section of the protocol that hopefully will help clinical staff if they're providing the service. The first one is the fertile window image, which is shown here, which helps you determine ovulation and risks of pregnancy. And then the next two slides, actually Dr. Novak is going to explain how the copper IUD insertion timing algorithm can be used and give a few examples.
Hey everybody, so I get the task of working through this algorithm. Fortunately, it's pretty easy. There's not a lot of reasons not to put in a Paragard IUD for emergency contraception. So in the end, most of these are green for go, or at least maybe a little caution, but still it's an option. So that, that's the big picture. The details are just trying to figure out where are you at. And, you're going to have to process a little bit of information from each patient to try to figure out how to get through this. But, again, this would be for somebody this algorithm is mostly for emergency contraception. If somebody's on an Explanon and you're taking Explanon out, putting in an IUD that same visit, not a problem, as long as they've been on a reliable form of contraception. But if somebody's coming in and it seems like emergency contraception would be a good option and an IUD would be a good option, then we really would like you to talk it over with the patient and see if that's acceptable to the patient. It is a much more effective form of emergency contraception than Plan B or even Ulipristal. So, this should be a good method for a lot of people. But, some things to be aware of. You have to have one in the clinic. So keeping one on the shelf for emergency contraception is always a good idea. The other thing is, you have to also think about how the clinic is working for you that day. If there's 12 people in the waiting room, you might have to work around that and do your best. We can't have people waiting 2 hours while you try to get an IUD in, bring the patient back, or refer them. But if it's possible, if you can do it, then this algorithm can help you. And essentially, we're dividing it up into has the person had or when was their last menstrual period is your first your cut point at the top there. And next slide, we've kind of broken it out to make it a little easier to follow. So if their last menstrual period was less than 7 days ago, or equal to less than or equal to 7 days ago, because the risk of ovulation is so low and the risk of pregnancy, assuming all other factors, they don't have an STD, then you could go ahead with placing the IUD. So then it gets a little more complicated once if it's been more than 7 days. So if it's more than 7 days, might consider a pregnancy test just to make sure they're not pregnant. And again, also some of it comes down to how well can you assess that it was a normal menstrual period for them. If their menstrual periods are all over the place, maybe a little more challenging. But if you're pretty sure of it, it was more than 7 days ago, pregnancy test is negative, then ask about unprotected sex. So if they haven't had any unprotected sex since their last menstrual period, again, the risk of pregnancy is extremely low. Of course, they may not be telling you the truth, but if they are, then, and we, can document that in the chart, then you're pretty safe to go ahead with the copper IUD. If they, let's see, next slide. So if all episodes of unprotected sex were less than 5 days, essentially, so negative pregnancy test, unprotected sex in the last 5 days, then that's a good reason to put the IUD in, and you're good to go. So it's this fuzzy area in the middle. Next slide. So if you got all of the episodes of unprotected sex were more than 5 days ago, well, it's not going to work real well for emergency contraception. Now, it doesn't mean you wouldn't put it in if you couldn't, but emergency contraception becomes, it's not a good option at that point. Or if some were, less than 5 days ago, some were more, now you're kind of like, well, maybe pregnant, maybe not, and so maybe a good choice for contraception for the exposure is less than 5 days ago. So then was where you start negotiating with the client. If the client prefers, after you discuss the risks and benefits, if they would prefer, you could give them another method to last them until you can bring them back for a copper IUD insertion or another method. So you would give them the pills, patches, rings, and or even a depot shot, and then bring them back in 2 to 3 weeks. And then you can insert the IUD. And then the other option is if they agree that, I can't get back in the office, I don't think I'm pregnant, it's extremely unlikely, then, and they understand that the IUD could cause miscarriage, or if they are pregnant today, then, and you want to document that, and if you feel comfortable doing this, then you could consider placing the IUD. And again, we're not going to hold anybody to a specific, this, you must do this. This is a little bit challenging, and you have to use your discretion as a clinician in these situations.
Yes, I agree.
Sounds okay? So we're going to try something. We'll see how badly down in flames I go here. But we're going to try doing a little pop quiz here to see how you guys absorbed that. So let's see and this is where that texting to that message comes in. So we're going to throw up a couple of very quick scenarios, and this is going to assume that somebody wanders in at 2 o'clock in the afternoon on a Friday, and let's see. So you've got a 15-year-old. It's not really that important about the gravidae, but she's 16 days after her last menstrual period, and she knows it was 16 days ago, and her last sexual intercourse was 11 days ago, so 5 days after the start of her menstrual period. If you guys want to, what do you guys think? Would you put one in, not put one in, or think about it? We'll give you about 10 seconds because we don't want to spend forever on this. Text away there. And A, if yes, B, if no, C, if maybe.
No charge to participate, right?
And there's no charge to participate. Right. It's not 80 cents a text or something like that. We're not making a profit on this. Okay, good. All right, that's what I thought too. Anybody? No, it looks like everybody agrees. Some of these are easy. Okay, next one. Let's try another one. Hopefully this is fun. We got a 28-year-old. She's 3 days after her last menstrual period, and the last sexual intercourse was 2 days ago. A, yes. B, no. C, maybe. Some of them get a little harder, but okay, good. Wow, does it tell you how many people responded? Did we just have one person who said yes?
I think it was second.
Is this?
So far, it's one person.
All right, that one person, very well. Yeah, it's happening so fast that it's kind of hard to, but okay, cool. Next one is a 22-year-old male. All right, anybody who says yes, let's talk. All right, next one. This one's.
It's on the adult phone.
Yeah. People are trying to catch it. Now, that one was just a kind of like, it's just seeing if you're awake. All right, no IUDs in males, please. Those are. We don't have a sound that's long enough. All righty, so this is. Whoa, lost that. Okay, we got a 19-year-old. Last menstrual period was 19 days ago. Last sexual intercourse was 6 days ago. What do you think? Oh, okay. We have one maybe. No, okay.
That's two people.
So this one's getting into the gray area. And so you're 19 days ago for your last menstrual period, but it's not, the IUD placement is not going to work for emergency contraception. You're outside that 5-day window. And you're at that kind of 13 days, assuming 28-day cycle plus or minus, you're in this kind of dangerous period where she might have gotten pregnant on this most recent, from the last exposure. So, this is partly your decision making. If somebody said, I really feel uncomfortable with this and placing it, it's too risky, then maybe start them on another method and bring them back for a pregnancy test. And then, but if you placed it, you know what? We wouldn't fault you on that either. And she might be pregnant, and then we would have to deal with it. But, you would document. Oh, one thing I did want to mention is in the situations like this, don't forget, to look at the how to be reasonably sure a patient is not pregnant. So family planning has those criteria, so those back you up. And there's even, we developed a little template in our electronic health record that you could go through and click on. So this will make sure you document it. You don't have to use it on every patient if they're clearly not pregnant, by any reasonable evaluation. You don't have to fill out that template. But in these situations, it would be helpful to be real clear that the patient made this decision, understands it, and you're not reasonably sure this patient isn't pregnant. So there's a little bit of risk, but the patient, you've gone through all the risks and benefits. So this one was a little more complicated.
I also talked to them about, if you were pregnant, what would you do? And when they say, I don't want to continue, I would not continue the pregnancy, that helps make it a little easier for me, and I document that. Also, there's some data that says that 5-day window is around the time of ovulation, so that actually extends it a little bit more. So if she ovulated, day 14-ish or 15-ish, you're still within that time frame.
Okay.
But your clinical discretion, absolutely. You're on the front lines. You do what is most comfortable and feels right for the patient.
I don't know, is everybody liking this, or no? Are we going too fast? Anybody want to text in that they're done with this, or that they want to keep going, try a few more?
We'll keep going.
Yes, it's
really good. Okay, let's do a few more.
Okay,
you're
ahead, I think.
Good. Okay. Alrighty. Again, young woman, last menstrual period was 25 days ago, and her last sexual intercourse was 2 days ago. So, yes, put it in. No, not a good idea. Or, yeah, maybe. Okay. That one person is really quick with their fingers. But very good. So the idea is we're talking about here is, you're probably assuming, regular menstrual cycle and stuff. You're probably well past ovulation, so the danger is pretty low, and it would work for emergency contraception because you're less than 5 days out. So, yeah, why not put it in? Maybe it's not necessary for emergency contraception, but since you don't know anyways, not a bad idea to put it in. But yeah, go ahead. Alrighty, another young lady with a positive urine HCG test. All right, very good so far. Anybody else? Clearly one of the major okay, you didn't even, that's a no-brainer. A major contraindication to placing an IUD is pregnancy, so you have other things to talk about. Alrighty, so we have a few more. We've got a young lady with, this one might be a little more challenging. Last menstrual period was 11 days ago, and intercourse was 2 and 3 days ago. Yeah. So, you're getting close to when she might be ovulating, but well within that 5-day window. So a good option for emergency contraception. Good. And this one I just made up. I mean, actually, they're all made up. I just pulled them out. I was randomly typing in dates and times. So, but I was trying to go for somebody who's like 65 days or his last menstrual period, so 2 months ago, and assuming they're normally pretty regular, and they had sexual intercourse 2 days ago, would you use an ECP here? Yes, no, maybe, ABC? Yeah, I think that's what I was thinking last week when I was writing these as well. Why is this why, if you did a pregnancy test and it was negative, then you might say, okay, what's going on? Maybe, and again, I sort of said in this case, she has regular menstrual periods. If she had irregular menstrual periods, maybe, something else is going on hormonally. So it's kind of a maybe situation. I think you need to do a little more work on this to figure out what was going on.
When I read this, I thought the first thing came to my mind was pregnancy.
And that would be a negative pregnancy test. We have had, this one makes me a little nervous, though. I'd be in the maybe category too, because we have had the urine pregnancy tests falsely negative at kind of this 2-month rate, just this J-hook phenomenon that Ernie could probably explain in a lot more detail. But I do know we very rarely had problems sort of with high levels of HCG in the urine that overwhelm the test. Mm-hmm. And so even with a negative, I would be like signs and symptoms of pregnancy, is this a usual thing? Anything changed? Maybe stress or something like that. Maybe she's just not remembering the menstrual period. So I'd be a little maybe-ish on this one too. Again, a negative pregnancy test would help me, but even then I might be kind of nervous. See if I could get a serum HCG, mm-hmm. that would be very helpful, but we often don't have that available. So, again, if you weren't quite sure, maybe start them on another method temporarily until you can get them to go, maybe send them to Ramit, and she can sort it all out. But it's possible you could put one in. Okay, next. And let's say we got a female 9 days ago was her last menstrual period. She last had sex 1, 4, and 6 days ago. So what do you think? Yes, no, maybe? Anybody else? Come on, this is fun. Okay, we must have 4 people, right? Yeah, so, all right. No, so why not? No, why no? I was thinking for this one it would be yes. It wouldn't help with 6 days ago she was 3 days after her period, so it's not very likely she's going to be ovulating that early. And 1 and 4, even that is, it's after that 7 days that we said on the algorithm. But it's within the 5-day window, so as emergency contraception, it would be a good choice. So, anybody have any?
The only caveat I would add is that this is all based on 28-day cycles, and
yes.
that if somebody does not have a 28-day cycle, which I think actually a lot of women don't, then it sort of shifts your so that maybe the maybe is coming from that. To ask her more questions about where she is and how long is her cycle. Yeah,
it's not perfect. It's somebody has a 35-day cycle or 6-day cycle. Your ovulation might be earlier, right? And so 9 days might be getting, and the sperm can hang around for a while, so you might be getting pretty close. But emergency ECP, Paragard works really, really well. So at this point, it should be okay.
Yeah.
Anybody want to text in a particular concern or change your answer?
Or would that be in the chat box?
Chat box?
Yeah, you can chat. You can chat now.
Oh,
you must have convinced her.
Yeah, maybe we did. Maybe something wasn't very clear there, but okay, that's why we're doing this. So, okay, next, we should only have a couple more. Well, I'll give a few more, but Alrighty, 30, G1, P1, last menstrual period 35 days ago. So again, actually in this one I was sort of thinking along the lines of longer menstrual period perhaps, or pregnancy. And last sexual intercourse was 2+ months ago. So yes, no, maybe. I didn't do the math on this one really well, so you could argue a little bit here. Yes? No. Back in here. I think in this one, again, it would go back to what is her period. Maybe she's ready to, if she 35 days is normal for her, or she's irregular and could happen any day now, and then you'd be a little less concerned. And the 2 months, you're not even putting it in for emergency contraception at that point. You're just placing one today just because it's a good idea. However, a urine pregnancy test might be nice to have just to document that you tested that. Again, if they're 2 months in, a negative pregnancy test is unlikely a false negative, but we have very rarely seen them. So just fix that. We've been burned a couple of times. If it was, I think there's other situations like twins can also create problems with that pregnancy test. But anyways, and last two, I think. Got two more. But a young lady, 14 days, last menstrual period was 14 days ago. Let's assume 28-day cycle. 14 days ago, and sexual assault 1 day ago. Yes, no, maybe. I think if Sharon is on, or a couple of others who have experience with Project SANE, they might have some real, it would be nice if they had any other additional comments. But I had that in mind. Yes, I mean, clearly this would be a great method. I think the legal issues around collecting specimens, the trauma from placing an IUD and how that might affect the Project SANE, their investigation, their documentation, would maybe be a thought, but certainly if they're right in front of you and placing an IUD is, this would be a very effective form of emergency contraception. Anybody else?
I think for her, the patient's needs would supersede anything else, and preventing pregnancy is really important, in addition to the prophylaxis that she would get for STI prevention.
And the difference is, I believe, SANE can't place IUDs.
Right.
So this would be something where if they show up with us first, we want to hook them up with SANE, and if they're willing. If they're not willing, then we still want to look after that patient in front of us and we replace this. But if they really are thinking about maybe eventually pressing charges and things like that, there is a concern, and I think coordinating with the SANE nurse would be really helpful to make sure you're not jeopardizing the prosecution.
You're absolutely right. I think I missed that point, but yes, if they should be seen by SANE before anybody else examines them.
Ideally, yes, and we would want to coordinate carefully. And the only reason I'm thinking about that is we're trying to work on a protocol around this to make sure we get it streamlined. So this was, we haven't quite finalized it yet, but it's in process. All right, last one. I've probably eaten up all our time, but here is a young lady, last menstrual period 17 days ago. Last sexual intercourse was 2, 6, and 9 days ago. So she, what do you think? Yes, you place one, no, or maybe? You can see you sleeping out there. No, okay. So no.
Not that one person.
Yeah, one person. So she's quick. She's quick.
Whoever that is, Susan Garrison, get off the phone.
Maybe. Okay. Yeah, for this one, I was in a maybe. Again, it's your call to some extent, but this, you've got intercourse 2 days ago, so that would help. But 6 days ago, assuming a 28-day cycle, you're getting pretty close to ovulation. I would probably, unless there's no way they were coming back and they fully understood the risks and like we said, you discussed, with the keep the pregnancy or not, I would probably look for maybe another method and bring them back in a few weeks.
I would.
Okay. But if they said, no, really want this, okay.
In the chat.
Oh, yes, actually, yes, there was a question in the chat, and it's in my notes. Concern of STD by placement. Is it Before placement. Well, as you guys know, for same-day insertions, we're okay with getting a chlamydia and gonorrhea test on the day of insertion and just following up as soon as you get those results back. And I just did this Thursday, and Susan Oviedo and I were...
I think that they were concerned about the sexual assault.
Oh, and the sexual assault one?
Yeah.
Well, you're going to treat them
Same way.
You're gonna hit them with treatment anyway. So that one I'd be even less concerned because you are you prophylax them with antibiotics. But in general, unless they had signs or symptoms of an active STD, we would place it, get a chlamydia and gonorrhea test, any other testing that's necessary as well, and then just follow up as soon as you can to make sure it's negative. And that's it for me. Do you guys have any? But yes, we don't let not having a chlamydia or gonorrhea test in the last 3 months stop you from placing an IUD. Collect it and then follow up. Yeah, so I think that hits. That's great. Thanks, guys, for participating. Your thumbs must be tired. Good job.
Okay, so mine, how do I follow this? Mine is very dry, but here we go. Hang in there, guys. So following up on the IUD section, some additional changes in this section, in addition to the Paragard as emergency contraception, includes return policies for all devices. Paragard, Mirena, and Nexplanon, these were all updated to guide you. So if you need to return these, pharmacy gave us input on how to go about doing that. The section when IUD strings are not seen during routine exams was added, and when an IUD user is found to be pregnant was also updated. Again, these were completely related to our discussions on the reproductive health echo, so really valuable opportunity there. Then moving on to sterilization form. Several things were updated here. We updated the sterilization request form and the sterilization provider evaluation form. This is now also available on the website for you, so it's a little easier to obtain and use for clinic staff. Appendix F was updated, and it is the current sterilization provider list for you. We actually are updating this Appendix F ongoing as clinicians or providers change. So every time you have a client that you're referring for sterilization, be sure to go online and look for that Appendix F. It'll give you the most current listing. In addition, we added some clarification to the sterilization section of the protocol around fee collection that's collected from percentage pay clients for sterilization procedures. It is considered non-refundable. There's more information in the protocol as well as in Appendix B, which is the fee collection. These fees can be used for other family planning services, of course, but it is a non-refundable amount, so that's something that clients should be aware of upfront. And lastly, the 2 weeks post-sterilization procedure visit that was in there, we did clarify this further in the protocol this year, so to know that it's not a mandatory visit. It's a nice follow-up visit, of course, but it's not required. And again, that's at our public health office. That's what I'm referring to. The pregnancy occurrences report in Section 2 was updated. We used to use this one just to report pregnancies for clients that are using Depo, and now we've expanded it to include clients that use Depo, Nexplanon, or Mirena who have an unexplained pregnancy. And the reason is we want to help determine efficacy or defect of the method. So if clinical staff identify a pregnancy with these methods, but you are able to identify the reason for the pregnancy. So, for example, they didn't use a backup method the first week of their use, or were late for the Depo shot, those sort of things. You don't need, to complete this form and send it to us. It's only for those that are unexplained, so that we can collect this information across the state and identify if there's any concerns about pregnancies. Moving on to Section 3, in the formulary section, the oral contraceptives chart was updated. Please note that the oral contraceptive pills that are no longer available in the U.S. market are highlighted with an asterisk, and so you'll see that with the big blue arrow is pointing at one there for you. We didn't remove them from the table yet because they can serve as a reference for clinic staff. If you have a client that comes in and says this was the method that they'd used in the past, that sort of thing, it can be a nice reference. But just to know that those ones that have the little asterisk are no longer available. And then to the appendices. Appendix A, the emergency medical response was fully updated. That's to Dr. Novak, so that's in there.
I think it's due for another update. But
Oh, well, it's current for the moment.
Yes.
And another update will come out. And all staff should review Appendix B, which is the fee collection protocol. Appendix D is staff orientation has been updated, so everyone, including supervisors, should review and be aware of that. And as I mentioned before, Appendix F, which is the referrals, will continue to update, and again, use that one when you're referring anyone out for sterilization. So, most importantly, out of all these updates, we wanted to thank you, all the staff who provide these really important services, for all the work that you do. We appreciate the services and care that you are providing to your communities. We also would like to extend an additional thank you to all of our protocol reviewers. They provide their expertise and their input to the protocol each year in addition to the service and care that they're providing in clinics, and this is really valuable to us. So in addition, I want to put a little plug in there if anyone is interested in becoming a protocol reviewer. Please feel free to contact me. My email is there, my direct phone number is there, or just call the main family planning program and they will track me down. We would love to have your thoughts and input.
And nurses are welcome too.
Yes, thank you, Manisha. Yeah, absolutely. Nurses, clinicians, and then Rihanna, when she works on the fee collection protocol, having the clerk involvement. And here we're talking about both provider agreement sites and public health office sites. It's not one or the other. All input is valuable, so we would love to have your input.
And you don't have to review the whole protocol.
No, that's another, thank you, Anisha. Very important is, so if it seems overwhelming, if you've ever read through the protocol,
Should have.
or yes, well, yes, but the entire thing in one sitting,
Yes.
it is quite extensive. It has some really good information, but it's a lot. So not to worry, we won't make you memorize the entire protocol. You can do sections of it if you prefer. For example, when we did the IUD as emergency contraception this year, some clinicians gave us feedback just on that section, and that was very valuable. So it's whatever you're able to provide, that's very much appreciated. And then before we move on to the questions and answer sections, we do have some additional supplies at the Family Planning State Office that we wanted to offer. It's a first come, first served basis. Again, it doesn't matter if you're a public health office or provider agreement site. On the left, we have pelvic models that are available. These are actually the ones that come with the NuvaRing example, but they're great for other client teaching as well. And then we also have the new Family Planning floor standing banner. We sent these out to clinics, but if you'd like additional ones, we have some available. They can be used for outreach or other settings. So please feel free to let us know. To order these, again, you'd use that Appendix C form. Just write in the items that you're interested in and send it in. And if we have them available, we'll be happy to send them out. We'd much rather they be in your hands than ours.
Thanks, Peg. And I think now we're going to move on and open it up for questions. Noelle, have we had any questions come in on the chat? All right. Anybody out there who has some questions that they want to share with us? We'd love to hear you and see you. Get some questions.
Hi, this is Carol, and
Oh, great.
the Roswell staff, and we do have a question. That's my question about the
All right. So I think we have some frequently asked questions that we can go over that maybe you might think about, but just not right now.
Yeah. So these are some questions that we've collected through the year. And so we thought if one person has a question, it's very helpful to share it with others. So again, don't feel shy about asking us. So one of the questions that came in that we get frequently is, when can I submit the CE&O survey? And I think Julie is going to help us answer this one. And Julie should be at the clinic site with Rihanna.
Yes, this is Susan. Julie just came into the room. Could you please repeat the question, Peg?
I think, Julie, you're unmuted.
Can you hear me?
She's in her office and she's in the bottom right. So I'm sure she
Oh, can you hear me? Hello?
I'm trying to talk.
You have any thoughts on this?
Unmute Julie.
Could you type that we unmuted, please?
It's not that she's muted the sound bar went dead. Try it now.
Julie, are you there?
Underwater.
We can hear you punching on the keyboard. Sorry.
I'm scared. That was noisy. Can you hear us?
Yes, there you go.
So can you please repeat the question and I'll type the answer?
We can hear you now.
You can hear us?
You can hear us?
Yes, we can hear you.
Okay. Okay, sorry. Could you please repeat the question? Julie was just coming into the room.
Yes, absolutely. So the question is, when can I submit a CE&O survey? And you might want to explain what a CE&O survey is for people.
Okay, so surveys are actually open from the time that Rihanna sends out the link to that month's survey until the 5:30 p.m. on the 15th of the following month. So that sounds a little confusing. So for example, this month, August CE&O survey will close September 15th at 5:30 p.m. If the 15th should fall on a weekend day, it will be Monday at 5:30 p.m. the following Monday.
So the community education and outreach survey, in short for CE&O, is something that the Title 10 grant collects, right? And it's important because you can only provide outreach and advertise for your services if you don't have enough clients to fill up your clinic, or if you make a community effort to collaborate with the other agencies. That's what the CE&O survey is about, right, Julie? Want to help me out here a little bit about what you collect and why is it important?
Right, correct.
Yes, we collect information on the number of outreach events, the type of person that receives the outreach, and also when there are educational sessions done, we collect information on the type of educational session. And it is something that's in the work plan for the grant, but more important than that, as Lanisha mentioned, it's something that really helps the community to know about our services. And that's why we realize everyone's short-staffed, but if you ever have the opportunity to do outreach, or if you ever need promotional materials from us, such as the Birds and Bees promotional materials, we'd be more than happy to send them to you.
Great. So the next one also is about the CE&O survey. I work at multiple public health offices. Can I enter more than one CE&O survey?
So the simple answer to that is yes. The survey itself is designed to allow multiple entries per user. This means that anyone who is entering the CE&O for a particular health office can, for example, have an event today, return to their office and fill out their information for today's events. And then if they have another event, say 2 days from now or next week, they can do the exact same thing, go do the event and enter for that event separately. The same thing applies if a staff member is working in multiple sites. The only thing there is just make sure that when you select your proper office on the drop-down menu.
I'm going to go rogue here asking my question. I don't work for public health office, but I'm a Title 10 provider, and I do outreach all the time. I even do health fair. When can I share with you guys, kind of want to contribute here? Can I do that?
That is something that is covered during the site visits. When a contract Title 10 clinic site has a site visit, then the site visit team will talk to them about the outreach they do. Though, of course, if you're a contract site and you have some great outreach ideas or anything that you would like us to send out in maybe the Public Health Division weekly summary or let others know about, we'd be more than happy to hear from you.
I think we do have a clinical question from Roswell. Lisa McDonald shared this with us. So how long do you need to wait, if at all, to insert an IUD in a woman who you just treated for gonorrhea, chlamydia, and wants an IUD?
That-
I
Agreed
give
on that.
them a week. So if I have a documented gonorrhea chlamydia and I treated them, I'll have them come back in a week, as long as they did take their meds. There are many STI experts who say that even by 3 days, the medications have made their impact and have taken effect. And also there's a lot of data that says many times patients don't even continue meds beyond 3 days, right?
That is
Alex?
true.
So, if you wanted to bring her back in 3 days, that's probably fine, but my practice has been I just do a week. And of course insist that they don't have sex again and that she's protected and please use condoms, etc.
Can you hear me?
Yes.
So one of the questions I guess that our provider has had is that the protocol says they have to have a negative on the books within 3 months before. So she doesn't want to do it until we have a negative.
And then you're going to need to wait at least 3 weeks, more like usually say 4 weeks to get the NAT test back and negative. So
I don't know. So here's where maybe the MEC will part ways with the DOH protocols and maybe they can be updated. But I think the MEC probably says in the selected practice guidelines that you don't need to do that.
not ideal, but it's probably safe enough. So if you just treat it was negative, but they didn't get reinfected or failed treatment at some later date, if they didn't, then at least having documented that you advise them to come back just to make sure would be good.
So maybe we can look at that part of the protocol and see if what information we can get from the MEC and SPR and update it.
So this is like
That's a great question.
Yeah,
Thank
it's
you.
an excellent example too, what we were talking about through the reproductive health as we did these cases and as people had questions. This interaction really helps us define what things do we need to look at with the protocol update, or is there something that we're missing. So it's a fantastic question and great discussion, and it is on our list on our review for a protocol.
That's why we need you as a reviewer, Lisa.
Yes. Let us know if we can add your name.
Yeah. So I guess maybe until we fix the protocol, is there any, maybe we could talk to the provider and discuss it. It is their call in the end, but we want to make sure they're using the best advice and giving the best care to the patient. So, I think we were saying a week would be reasonable.
And document it, and if you wanted to just, call the PALS line and talk to one of us and say, you can also include that, because I will do that when I am consulting for, say, MFM, things that I need experts for, that, I just, in conversation with Dr. So-and-so, plan was agreed upon. So that will help you and probably make you feel better about, okay, I'm okay about putting it in.
Okay, thank you. And of course, if she were in there and it was really inflamed or something, she would wait.
Yes.
But,
yeah. I agree.
Okay, thank you.
Thank you for the question. Do we have any other questions from the network? And feel free to talk, chat if you're shy. We're happy to hear from anyone.